In myocardial infarction, the most common cause of death is arrhythmia. Disrupted electrical signals cause the heart to beat irregularly, leading to ineffective pumping and sudden death. The most common site of myocardial infarction is the anterior wall of the left ventricle. This area is supplied by the left anterior descending artery, or LAD. Blockage here can cause severe damage and complications like heart failure. In myocardial infarction, ischemia triggers the earliest change, coagulative necrosis. The nucleus shrinks and cells and becomes granular. This irreversible damage spreads through the tissue. Troponin is the most specific marker for myocardial infarction. It's a complex of 3 proteins, C, I, and T. In a heart attack, troponin is released from damaged heart cells. This makes it highly specific. CKMB is a cardiac biomarker that rises after heart damage. Levels peak and then fall, as shown in this graph. A second rise indicates reinfarction, a new cardiac event. Second heart attack risk spikes after first damage. CKMB levels rise again to signal danger. The CKMB peak indicates initial heart damage. A second peak rises, signaling a reinfarction. CKMB rises again to detect it fast. The shock index is calculated by dividing heart rate by systolic blood pressure. A shock index greater than 1 suggests the patient may be in shock. This simple calculation is a quick way to assess a patient's condition. Hypovolemia, or low blood volume, triggers the body's compensatory mechanisms. The heart rate increases. Tachycardia is the most sensitive and earliest sign of hypovolemia.
The first step in shock management is IV fluids. I'm starting an IV now. Fluids are running. This will help stabilize you.
Oxygen delivery is the product of hemoglobin and cardiac output. Hemoglobin carries oxygen in the blood. Cardiac output is the volume of blood pumped per minute. Together, they determine oxygen delivery. Cyanosis is a bluish skin discoloration from low oxygen. It requires at least 5 grams of deoxygenated hemoglobin per deciliter. This threshold causes visible blue changes in the blood. In metabolic acidosis, excess H ions move into the cell. This causes K+ ions to shift out of the cell to maintain charge balance. The result is hyperkalemia, a high serum potassium level. Hyperkalemia disrupts cardiac membrane potential, slowing conduction and leading to peaked T waves on ECG. Excessive K+ ions crowd. In respiratory acidosis, the lungs fail to remove enough carbon dioxide. The kidneys compensate by reabsorbing more bicarbonate into the blood, which neutralizes the acid and raises pH. Kidneys reabsorb bicarbonate while excreting more hydrogen ions, slowly restoring blood pH toward normal as compensation continues. In primary hyperaldosteronism, the adrenal gland overproduces aldosterone. Aldosterone acts on the kidneys. This leads to hypertension from fluid retention and hypokalemia from potassium loss. SIADH leads to low serum sodium and high urine osmolality. In SIADH, the body retains too much water, diluting sodium levels in the blood and concentrating the urine. In SIADH, the body retains too much water, diluting concentrated carnipsetter. This causes cells to swell and produces highly concentrated urine. Observe the golden urine sample as we zoom in to reveal tiny crystals forming, indicating a kidney silhouette pulses rhythmically, representing osmolality waves that concentrate the urine. In diabetes insipidus, the pituitary gland fails to produce enough ADH. Without ADH, the kidneys cannot reabsorb water, leading to high serum sodium levels.
In central diabetes insipidus, ADH deficiency causes the kidneys to excrete large volumes of dilute urine. During a water deprivation test, the serum fails in wells remain dosate, a key feature of the condition.
The anion gap is a calculated value representing unmeasured ions in the blood. The formula is anion gap equals sodium minus. This helps identify metabolic imbalances. High anion gap causes are remembered by the mnemonic MUDPILES. M for methanol, U for propylene glycol, I for isoniazid or iron, L for lactic acidosis. Let's update our mnemonic for high anion gap causes. We add U for uremia and P for paraldehyde and propylene glycol, I for iron or isoniacol, MOPAR, M for methanol, D for diabetic ketoacidosis, U for uremia, P for paraldehydes, and S for salicylates. The most common cause of hypercalcemia is hyperparathyroidism. This condition causes the parathyroid glands to release too much parathyroid hormone, leading to elevated calcium levels in the blood. Hormone thyroid produced is overactive. This hormone enters the bloodstream, causing calcium theta levels to rise dramatically. This can lead to serious health complications. The most common cause of hypocalcemia is vitamin D deficiency. Vitamin D is crucial for calcium absorption in the body. A deficiency in vitamin D leads to low blood calcium levels. Albumin in the blood binds calcium, forming the bound portion of total calcium. This binding affects total calcium levels. So, ionized calcium remains free, not ionized calcium, like P.
Albumin binds to calcium, but only ionized calcium is active. That's why we measure ionized calcium for accuracy.
Hypokalemia is a condition of low blood potassium. This can cause changes on the ECG, like these U waves. U waves are a sign of delayed repolarization.
Hypokalemia, or low potassium, causes delayed ventricular repolarization. The U wave becomes more defined with each heart.
Hyperkalemia, and elevated serum potassium, disrupts cardiac cells. This alters repolarization seen as peak T waves on the ECG. Prompt recognition of these changes is crucial for patient care. Beta blockers inhibit the release of renin from the kidneys. This decreases the activity of the renin-angiotensin system. This mechanism helps in managing conditions like hypertension.
Beta blockers block beta-1 receptors on juxtaglomerular cells, causing renin secretion to drop sharply and the kidney to glow dimly in response.
It's important to know that ARBs do not cause cough. Unlike ACE inhibitors, ARBs are not associated with that side effect, so you can take them without worrying about a persistent cough. But your persistent cough, that's not the ARB. Let's find what really is. For patients who experience a cough from ACE inhibitors, ARBs are a safe and effective alternative. They work similarly but don't cause that side effect.
Loop diuretics inhibit the reabsorption of potassium and calcium in the kidneys. This leads to increased urinary excretion of these ions. This mechanism is key to understanding the effects of loop diuretics.
Loop diuretics inhibit reabsorption of K+ and SO2+ in the thick ascending limb, causing increased urinary excretion and resulting in hypokalemia and hypocalcemia.
Thiazide diuretics can lead to hypercalcemia. Here's how. Thiazides inhibit a sodium chloride cotransporter in the kidney. This causes more sodium to be reabsorbed, in exchange calcium in the blood, causing hypercalcemia. A thiazide molecule floats toward the distal convoluted tubule. It binds to and blocks the sodium chloride cotransporter. The graph showed calcium levels that are emissated into deadstream. The kidney's distal tubule reabsorbs more calcium into the bloodstream. This causes blood calcium levels to rise sharply, an excess of calcium in the blood.